chickenpox in pregnancy. So I must say this is one of the important guidelines, both from your exam point of view, like for the MRCOG part 2 and 3, as well as for your daily clinical life also. So let's start. Okay. So today we are going to learn the introduction of varicella zoster virus, the varicella prevention and its treatment, and what are the maternal risks of this virus in pregnancy, fetus, or the baby, and plus how it is diagnosed prenatally and how to prevent maternal and the fetal risk when a patient or the person has got this chickenpox infection, right? So let's start with this. We know that this chickenpox virus, the varicella zoster virus, is a DNA virus of a herpes family that is highly contagious. It has been transmitted by the 3 ways. Number first, the respiratory droplets, and by the direct personal contact, that is a contact with the vesicular fluid, or by the indirectly via formids. It could be any form, skin cells, hair, clothing, bedding, anything. Okay, so see how contagious it is. Once a patient or a person get in contact with it, they will get infected, and the infection are basically of 2 types. One is primary, another secondary. The primary is very important, and that has been characterized like all other viral infection, that is fever, malaise, but with a typical rash appearance, that is a pruritic rash that develops into the crops of maculopapules, which later become vesicular and crust over before healing. All right. And the UK Health Security Agency advises that the infectious period of this virus in immunocompetent individual is from 24 hours before the onset of the rashes until 5 days after the rashes, right? So my dear friends, this is the new one, right? This is a new edition of this guideline that has been modified. Initially, it was like 48 hours before the onset of rashes, still the rashes has been crossed over with the period of a time, but now they have compressed it from 24 hours until the 5 days, because probably it's the 5 days when the rashes get crossed over. Is that clear there now? So this was in case of immunocompetent people. However, we should not forget the immunocompromised as well. So immunocompromised individual, it may be infectious for a longer period of a time, period from at least 24 hours before the onset of rashes until all the lesions has been crusted over, right? So it's a bit longer. Before 24 hours, even before 24 hours, still all the lesions has been crusted over. So that is the very important lines for your exam questions and the scenarios as well, right? Let me just cancel this one. Yeah. So the question is, can the non-immune woman be immunized prior to the pregnancy or postnatally? So the answer is yes. There are the vaccinations called as a varicella vaccination that can be given pre-pregnancy or postpartum. It's an open option and should be considered for the women who are found to be seronegative for the varicella zoster IgG, right? However, the universal serological antenatal screening is not recommended, but if we found or identified the seronegative women in pregnancy, they could be offered postpartum immunization. All right. Why we are giving it pre-pregnancy and post-pregnancy? Why not in pregnancy? Because the varicella vaccine has got a live attenuated virus in it. There are two types of vaccine, the Varivax and the Varilix. And they can be administered in 2 doses, and the doses should be at least 4 to 8 weeks apart. All right. And since it is a live attenuated viral vaccine, there are 3 important things we have to tell to the patient. Is that number first, avoid pregnancy for at least 4 weeks, right? Number second is avoid contact with a susceptible pregnant woman. Why? Because even though she has been vaccinated, but still it's a live virus, there are chances for the post-vaccination rash. And so ultimately it could be transmitted to these susceptible pregnant women, though it is rare, but the chances are there, right? So that is why it's very important to alert them to take care of themselves and not come in contact with other susceptible pregnant women or the newborn. Okay. And it's very important to tell them it's completely safe to breastfeed if they are getting it injected during postpartum period. Okay. Till then, till now, is this clear for you people? Okay, you can comment in chat box any question anyone has in between. All right. So what happens when a pregnant woman come in contact with a chicken pox or the shingles? Okay, before that, just can anyone of you tell me what is exactly chicken pox and the shingles? What's the difference between them? Anyone can write in a chat box. What is the difference between these two? Okay, that's right. Yes, Mohammed bin Kamar has correctly commented. Well, that's true. Well, that's true. So yes, chickenpox is a primary infection when the person is been exposed for the first time, and shingles is something that is reactivation of the latent disease in any person. That's correct. But see, here in this slide, we have written that when the pregnant women come in contact with the chicken pox or the shingles, it means there are chances that both are contagious. It's not that the dormant one which now come which has now come out, maybe it's safer. No, it's not safer. It is also contagious, right? So remember this thing as well. So what happens when it occurs? So when a contact occurs, the chicken pox or the shingles, what is important is a careful history must be taken. A very careful history to confirm 2 important things. Number first, the significance of the contact. Number second is the susceptibility of the patient, right? So how we'll confirm this? We'll confirm this by taking history. So what is that? Number first, the type of a varicella zoster virus infection was when she was being exposed, whether it was primary, secondary, and what was the timing of the exposure? What was the closeness and the duration of a contact? So these are very important things to be asked. That is important again for your part 2, part 3, your daily clinical practices as well. Okay, so in previous slide, we had studied that if anyone is acquiring chicken pox, then he or she is infectious for at least 24 hours before appearance of the rashes till the lesions are active or until 5 days, right? But in cases of herpes zoster shingles, it also poses a risk if there are 3 things for that. Number first, if it is disseminated, all right, or it occurred to some exposed area of a body like ophthalmic shingles, right? Or in case the person who are having this shingles has been immunocompromised individual, because in immunocompromised, they'll be shedding more and more this virus and they're more contagious, infectious. So there are 3 conditions. One is when it is disseminated. Second, though it is localized, but it is on the exposed part of the body. And third, when it is in the immunocompromised individual. All right. So that is important. 3 things to be remembered. However, the risk of infection following contact with the herpes zoster that is not in the exposed area, like in the back, thoracolumbar is remote, but it can also occur, right? So there is also chances, but a less chances for number two. Here, in exam, a tricky question also comes across. That is, a pregnant woman has been exposed to the shingles of a thoracolumbar region, but it is of the husband. So tell me whether she is at a high risk or low risk for getting this or contracting chicken pox in pregnancy. Please comment in the chat box. If a pregnant woman is exposed to thoracolumbar shingles, but the shingle is for husband, that whether she's at a high risk or the low risk for contracting the disease. Well, that's correct. She's a high risk. Why? Because it is now the direct area of exposure to her. That's correct. That's correct. Yes, yes, Dr. Aisha, that's correct. That's correct. So, very good. Let's move to the other slide. So in history, these three questions are important. Number second is the significance of the contact, the duration of a contact. So what is a significant contact? Is that a contact in the same room for 15 minutes or more, a direct face-to-face contact, or a contact in the settings of a large open ward. Okay. And the significant exposure can be continuous, it can be multiple, it can be even a single exposure, right? But the duration also matters. See, so if we practically see it, it's like all kind of exposure we are getting could lead to contract this virus. And so after history, to see the duration of that, we have to see the susceptibility of the patient as well. And how can we elicit it? By, again, taking a detailed history. History of what? Past history of chickenpox, shingles, or the varicella vaccination. So we have to ask her that whether, because, the study says that if anyone who has got a previous infection, there are 98% chances that they got a lifetime immunity, right? So that is why if they do have history, they are reasonable to assume that she is immune. But in case if they do not have history or they are unsure of that, or they belong to tropical, subtropical areas, we have to go for the serum levels of varicella zoster virus, IgG levels. These are very important to do to determine their levels. If it is greater than 100, it's positive. It means somewhere in past she was been exposed. Now she is immunized. She does not have any risk. So just reassure her, that is it. But in case, if it is less than 100, then start the PAP. That is a post-exposure prophylaxis, right? Now in other slides, you're going to read what exactly the post-exposure prophylaxis is, right? So is that clear till now? Now, this is an important slide, this one, is that though we understand, so these levels and everything was for the people who were immunocompetent, right? But again, we have to consider immunocompromised people as well. And that is, if a pregnant woman is immunosuppressed for any reason other than that of the pregnancy, either previous history of infection, vaccination may not be sufficient evidence of her immunity. We need to go and check her varicella zoster virus IgG serum levels as well. Okay. And in case if it is low, we have, if it is negative, or in case if the titers are less than 150, we have to give her post-exposure prophylaxis. So from this slide, we understand that we have to keep a low threshold for giving them post-exposure prophylaxis because they are more at risk of contracting the disease and developing complications. And it is one of the very important slides. Okay, so very good algorithm for the management of varicella zoster in pregnancy. So this has been divided into two parts. One is this part where we give prophylaxis measure and other is a therapeutic measure, right? So prophylaxis, my dear, till now what we have talked is that she was just exposed. She is at risk, but yet she hasn't developed any rashes or she hasn't developed any clinical feature of chickenpox. So that is why we are giving them varicella virus vaccination, sorry, the immunoglobulins or PAP we are giving to her. Okay, so number first, if we read this algorithm, we found that if there's a contact with varicella zoster, then clarify the significance of contact that we read in the previous slide. If they have a past history of chickenpox or they had a 2 doses of vaccination, reassure. But if she is uncertain, no past history, or the woman from tropical or the subtropical country, go ahead and check the levels of IgG. Okay, greater than 100, reassure and return to the normal antenatal care. Okay, but in cases, if it is less than 100, go and get the treatment. And what is that post-exposure prophylaxis? It is actually in the two forms. One is the oral and other is the immunoglobulins, right? The first line management or the post-exposure prophylaxis is oral acyclovir. That is the new change in guideline that anyone who has been coming and they are completely fine, does not have any contraindication with oral antiviral drugs, offer her oral cyclovir, but from the day 7 to the day 14 post-exposure, right? Why from the day 7, not before that? Because because various of the studies shows that if it has been given before, it doesn't show as effective as it should be, right? So that is why from day 7 to day 14, that will be equal to total 7 days. And what would be the dose? It would be 800 milligrams 4 times daily, right? In case, and you must remember that once you're giving to medication to anyone or any of the patient, you must remember the side effect for that. That is headache, dizziness, nausea, vomiting, and the diarrhea, right? But in cases where patient is unable to tolerate the side effects or there is some contraindication with this oral antiviral medication, then we have to give the IgG to them. And what is that? These IgGs have been taken from the human plasma. Okay, these are the ready-made immunoglobulins. We inject them in order to prevent the infection in these people. But it should be given as soon as possible or at least within 10 days. So that is important, right? We should not wait for at least 7 days, but we have to give it either as soon as possible or maximum within 10 days. That is it. Okay. And 10 days since it has been, the person has come into contact with that infectious. But in cases when there is a continuous exposure, then it is less than 10 days. We have to count since the index case has got a rash. Okay, so there are two things to be understand from that. One is that if the person has only single exposure or the multiple exposure, that is it. We have to give her as soon as possible or within 10 days. But if he or she is in direct contact or continuous exposed with that infectious people, we have to give her within, within a 10 days, but we have to count the appearance of a rash in the index case. Am I clear so far till now? Is this part clear? And remember the side effect, since it is when injectable, so pain and erythema at the site of injection, and a very less than 0.1% chances of anaphylaxis with that. Okay, is that clear? All right. So this is what the prophylaxis we are giving till now when the patient hasn't developed or the exposed people haven't developed yet any sign or clinical features of chickenpox. But what happens when the person has exposed and developed chickenpox? So anyone who presents with chickenpox, initial contact should be with women's GP. So see here, she's coming to the GP, not directly to the other person, right? So she has to go to the GP. And GP will tell her to avoid contact with potentially susceptible individuals. Okay, this is the first line she has to understand. And number second is that we'll give her symptomatic treatment and hygiene should be advised to her in order to prevent the secondary bacterial infections, right? So these are certain important things. Now comes to the treatment. So we have also, what is the treatment in her? Here the timings are important. If the woman who presents with within 24 hours of the appearance of rashes and she is equal or greater than 20 weeks of pregnancy, prescribe her acyclovir, right? So within 24 hours and greater than 20 weeks, prescribe acyclovir. But what happens if she is less than 20 weeks? Consider acyclovir. So remember these words. If it is greater than 20 weeks, prescribe. If it is less than 20 weeks, consider acyclovir. And remember that avoid delivery of a baby until 7 days since the rashes are. Why it is so? Because we let the passive transfer of antibodies right from the mother to child. Okay. And meanwhile, the mother get also better in condition. Okay. But here, what is important is to consider the mother condition as well. Until unless it doesn't pose any additional risk to mother and baby, continue pregnancy at least for the 7 days. Am I clear so far? Any question till now? So this was a post-exposure prophylaxis, and this is once she got clinical manifestation of chickenpox. See, here another line is come that even women can develop chickenpox despite post-exposure prophylaxis. That is why anyone who has been coming with that, we have to inform her that once you got rash, go and get inform your GP and avoid contact with the susceptible people. We will tell her about the hygiene. Okay, and then according to the gestational age and the period of appearance of her rashes, we'll prescribe her acyclovir. Is that clear so far? Any questions till now? Okay, you can see this line, this arrow. Here we are talking about severe infection. When a severe infection occurs, here IV, the intravenous drug works, right? So what happens here is that a woman who develops severe infection. Now, what is a severe infection? I'll be telling you in the next few slides. And the women who are at higher risk of complication, okay, of chickenpox should be referred to the hospital. So these are the two conditions where women could be straight away referred to the hospital, not going to anywhere. So they'll be directly referred to the hospital, and intravenous acyclovir should be given to them. So see the severe infection and also the women who are at high risk of complication. Is that clear? All right. Okay. So what happens? Okay, if the infection is less than 28 weeks, hello? Mhm. All right. All right. So if the infection occurs in a gestational age less than 28 weeks, what is important here? What should we do? Number first, we have to tell her about the risk of having Peter varicella syndrome that is quite small, less than 1% or at least 1% in them. And in order to detect that, we have to refer her to the fetal medicine specialist. That could be at least 16 to 20 weeks or 5 weeks after infection. Can anyone tell why this time period is important? Why after 5 weeks of infection? Anyone please comment in the chat box. On? Yeah. Okay. Well, not a window period for clearing the infection. Just for the appearance, to find out the appearance of that characteristics of fetal Varzala syndrome. I'll be telling you what is the fetal Varzala syndrome, what are the characteristic appearance for that. So when we refer them to the fetal medicine specialist, they will get some detailed ultrasound to find the characteristic features of that. So it will take certain time to develop that, and that is why we will send them or refer them for detailed ultrasound. Okay. Yeah, that is the reason. Okay, and there an amniocentesis could also be considered to detect this DNA of the virus via the PCR test. Okay, so that is it. Now here I would like to make sure that you people remember two important thing is the dosage of the drug. See, when we are giving it post-exposure prophylaxis, we have to give 800 milligrams 4 times a day, right? But when it comes to the therapeutic, we have to give it 5 times a day. It has gone, okay, it has gone higher, but so it is 5 times a day, and that was post-exposure prophylaxis was 4 times a day. So remember, though the duration is same, but the dose is different, and that is the exam question. All right. But again, but here in other slide come is that what happens when a further exposure to chickenpox occur during pregnancy. Just understand that we are on the left side of algorithm where the patient has been exposed and not yet developed any infection. We have given her PAP and everything, but she has got she has been re-exposed to the chickenpox once again. So what shall we do? Okay, so here testing for varicella zoster IgG should be repeated regardless whether or not the PAP was prescribed after the initial exposure. Okay, and check whether they have got a seroconversion or not. If there's a no seroconversion, then start PAP. Okay, then we have to again give her post-exposure prophylaxis for that. And again, the dose for the cyclovir oral tablets is the same. However, the immunoglobulins we have to give it at least 3 weeks or more after the last dose, right? So that is very important. Any kind of immunoglobulins which has been repeated, there should be at least a 3 weeks difference for them. Okay. So is that clear till now? Amniocentesis for viral DNA. Yes, amniocentesis has been done for the viral DNA to find out whether the virus is there or not, and that has been done by polymerase chain reaction test. And following exposure, it is in 20 weeks to be considered antiviral. Yes, that's right. Any gestation, if the patient has been coming, and if we require to give them prophylaxis, we can give it to any gestational age, no matter whatever period she is having of a pregnancy. For a post-exposure prophylaxis, just give it to her. But in case of therapeutic, we have to consider and think. Okay, so that is important. Is that clear? Even if she is immune of what? Can you please clear this? No, my dear friends, as I said that if we go back and goes there, is that, see, when anyone who has been exposed, you have to make sure that whether she has immunity or not. Here, if she says that I have got an infection in my previously in my childhood, or I've been vaccinated with that, just reassure her. Or in cases, but in cases where she is unsure, or she is belongs to certain areas where it is uncommon, we have to check her immunity. If she is immune, greater than 100 is immune, just reassure and routine care. No need to give any PAP. But in cases, if there is not no immunity, it is less than 100, then start your PAP. And only PAP has been given when she hasn't developed any clinical manifestation so far. Okay, is that clear? All right. Okay, that's great. Okay, so the exposure we have done. Now see, why it is very important. Why it is very important, immediately to educate that woman so much for the chicken pox. Why it is important to give them post-exposure prophylaxis at any period of their pregnancy. Why it is important to treat their chicken pox so vigilantly. Why? That indicates that she has got certain severe maternal risk for this infection in pregnancy. And these are pneumonia, hepatitis, and encephalitis. And rarely even it can result in death. See how how much complicated it could be in pregnancy if we cannot treat the women properly or timely. So that is why women should be told about the red flag signs, that whenever she has developed any respiratory symptoms, neurological symptoms like photophobia, seizures, drowsiness, or appearance of hemorrhagic rashes, bleeding, dense rashes with or without mucosal lesions, these are indicated of potentially life-threatening chickenpox, or and are indications for referral to the hospital with ICU access. See, if we go back, I told you a complicated here in this, that okay, a woman who developed severe infection. So these were the signs of severe infection. Okay, pneumonia, encephalitis, and the dense rashes. So that is a severe infection. And but there are certain other women, like women at high risk of getting complicated. And which are these women? These are anyone who smokes, has a chronic lung disease, who is immunosuppressed, even including those who have been taking systemic corticosteroids for the preceding 3 months, or even the woman who is in her second half of the pregnancy. If you find any of this feature, straight away hospital assessment should be considered, even in the absence of complication. Even if you didn't found any kind of complications, she is completely fine, still refer her to the hospital for detailed assessment. Okay, and but in hospital she'll be also taken care in isolation, so they cannot be exposed to the other people there. All right, so a very important slide from your exam question for the board, part 2, part 3 candidates. Do remember that. All right, so this was the clarification of this part of algorithm in pregnancy. Now come down to this. So what is the fetal varicella syndrome? It has been characterized by one or more of the following. So even if it is a one, it is a fetal varicella virus syndrome. That is scarring in the dermatomal distribution, eye defects. In this, everything is small, small, small. Small eyes, small head, small cortical atrophy, small limbs. So the microphthalmia, chororetinitis, cataract, hypoplasia of the limbs, that is a characteristic feature for that. Neurological abnormalities, small head, cortical atrophy, mental retardation, and even dysfunction of the bowel and the bladder sphincters. So that is these things we have to determine via detailed ultrasound. Okay, is that clear? All right. So this was when she was carrying pregnancy. But what occurs once a baby has been delivered? How about neonatal risk of getting varicella viral infection in pregnancy? That is important. If a woman infection occurred in the last 4 weeks of women's pregnancy, the last 4 weeks, there is a significant risk of varicella infection of the womb. So you have to take care of these babies. That would lead to the congenital varicella syndrome. That is a syndrome or infection occurred in the early neonatal life. And it could be by any of the ways. It could be like if the maternal infection is near the time of a delivery or immediately postpartum, or even from the contact with a person other than of the mother with chickenpox or the shingles during this period. See, that is why we were telling the other people to avoid contact with the susceptible people. So it's not only the pregnant women, but also the newborn babies as very important slide. And what could be the route of infection? It could be the transplacental, ascending via the vaginal route. It could be result from the direct contact with the lesion during or after delivery. So, see, these are important. And up to 50% of the babies have been infected. See the ratio. But approximately 23 will develop clinical varicella infection. But what happens when there's a severe chickenpox infection in the womb? It is most likely to occur if the infant is born within the 7 days of onset of mother rashes, or if the mother develops up to 7 days after the delivery. So it is 7 days before or after delivery. That is the reason we were at least telling or advising to delay the delivery up to 7 days. So on the other side, mother get also better, and plus she could develop antibodies which can protect the baby as well. So if this condition occur, straight away, give the baby prophylaxis as soon as possible with these immunoglobulins, with or without these. And definitely be done in the presence of neonatologists and consultation with them. Remember, there is no need to do any test in these circumstances. There are, these are at high risk of contracting severe chickenpox. So straight away give them prophylaxis with or without visa. A very important question, again, from your exam point of view. However, yes, if she wants to get breastfeed, she can do it. In cases of active chickenpox lesion that is close to the nipple, they should express the breast milk from the affected breast until the lesion has been crusted. So that was all about the chickenpox. So anything so far, any question you people have till now? If contact within 7 days of rashes or after, we'll give this, but when we give this with acyclovir, well, that is again a decision. That is, you can give it with or without. I mean, like, it's both the time you can give. The role of immunoglobulin is just to immediately provide the baby immunoglobulin, like the passive immunity, because the baby hasn't got this passive immunity from her mother. However, in case if the baby develop rashes or the condition is worsening, the acyclovir could be given, but that is again could be done in consultation with a neonatologist. That has been not clearly defined in this green top guideline. Okay. Okay, so let's have certain questions. Let's see what you people have learned so far. Okay, can anyone solve this question? Let me read it for you. A school teacher who is 10 weeks pregnant reports contact with one of the people who has chickenpox. When you say this child was infectious, so was it? So read the option and tell me what would be the answer for this. Comment in the chat box. You have to solve this according to the new edition of this guideline. Yeah. Okay. Please, new guideline. All right. By 5. Please stick to the new guideline. This is a new addition to that, na? All right. Okay, let's move to the key. So the answer is 3, that is 24 hours before the rashes appear. Sorry. Before the rashes appeared and until it's crusted over, usually after the 5 days. So my dear friends, this is a recent update. Please do stick with this and forget the previous one. Though this is the previous one, which we used to follow is that 48 hours before and until the vesicles has been crusted over. But now, the UK Health Security Agency has advised that the infectious period of the immunocompetent is from 24 hours before the rashes until the 5 days. That is it. However, in cases of immunocompromise, the period is extended. That is longer than from 24 hours before the rashes until all the lesions has been crusted. Am I clear? Is this point clear? All right. Okay, great. So let's move to the next question. Anyone who can attempt this, even in fact, everyone can attempt this. So what advice would you give a 20 years old from Nigeria at her booking visited 12 weeks of pregnancy uh, if she has a history of not having chicken pox in the past? Mhm. Right? Okay, and the answer of this question is undertake the serum levels of IgG test. Okay, the reason is that anyone who has not any history for that, we will get a check and offer her postpartum immunization. The reason is that. All right. So this is a note. Okay, let's move to the next one. Okay, the question 3 is a pregnant woman in her 24 weeks of pregnancy reports contact with a friend who previously has shingles. What type of a shingle poses the greatest risk to this woman if she is susceptible? Remember the exposed, unexposed, remote area. Mm-hmm. Yeah. Mm-hmm. Good. Yes, most of the you are right. That is the exposed area. See, what is the exposed area? Yes, this one, the four one. It's correct. It's very good. It's the thymus shingles. Okay, remember this. This slide is very important. Okay, the last question for you people is at 29 years old, Gravlatri Paragon delivered a full-term male infant 3 days after she developed a chickenpox rashes. She was commenced on oral acyclovir as soon as after the rashes appeared. How will you manage the baby? So the baby is born and 3 days after she developed chickenpox. So what would the treatment of baby, not the mother, because she's already taking the acyclovir? Oops, oops. Okay. All right. Okay. Most of the people are right, and that answer is 3. That is with or without acyclovir. That is correct. That's correct. Well done. Very rightly, the most of the answer is right. So well done. I hope you understand the minor changes which has been included in this green top guideline of chicken pox and pregnancy. Till then, any of the question or any slide you want me to clarify you more, please comment on chat box. So is that clear till now? All right, you're most welcome. Okay, any questions so far? Mhm. All right, so you can contact the team for this. Yes, the backend team will be definitely sending you the details for that. Just message them. Yeah. Okay. The Telegram. All right, it is soon provided to you. Okay, so no question till now. Okay, that's great. Okay, so till then we are here done with our session. Thank you so much, my dear friends, for joining in. Here are the links provided to you. Okay. All right. So take care, study hard, read it again so that you can memorize that in a proper way. So do solve the problems or these question books are very important. Once you read any Green Top guideline or anything, straight away go ahead and solve your books. Concentrate on them in order to retain it for a longer period of a time. Okay. All right. Thank you so much. Okay. Take care. Take care. Hafiz. Hafiz.